Good morning. I'm Dr. Archana, consultant anesthetist and assistant professor, Mallareddy Medical College for Women. Today I'm going to present airway devices and airway equipment that help us in the ventilation of the patient. First basic equipment is a face mask. It allows administration of gases to the patient from a breathing system without introducing any apparatus into the patient's mouth. So it is like a non-invasive equipment. The modern face mask can be made up of black rubber or clear plastic or elastometric material. So the parts of the face mask are the seal, connector, as you can see here. This is the body of the mask, the orifice, and the seal can be either it can be rigid sealing. And we have a connector which is a 20 connector, anatomical mask. It has slightly malleable rubber body, a sharp notch for the nose, and a curved chin section. Then we have special mask for the pediatric group. This is called the Rendell-Baker-Sosek mask. It is designed for children of less than 10 years of age, triangular in shape, and it has less dead space. Can also be used for the tracheostomized patients. Then we have the endoscopic mask. It has a port or diaphragm in the body to allow the insertion of the endoscope. So indications of mask ventilation: when you want to pre-oxygenate the patient before giving general anesthesia with anesthesia circuits, we can use it with ambu resuscitated bags, failed endotracheal intubation, awake or lightly sedated patients requiring a high inspired oxygen concentration. Contraindications: known increased risk of vomiting or regurgitation and known significant airway obstructions. Advantages of face mask as compared to tracheal tubes: requires less anesthetic depth, no need of muscle relaxants, and lower incidence of sore throat. Disadvantage: anesthesian's hands are tied up. Higher fresh gas flows are often needed. Gas insufflation into the stomach if ventilator pressures exceed 20 centimeters of water. Minimal protection from aspiration of regurgitated gastric contents. Often more episodes of oxygen desaturation. So we have two techniques for holding the mask. When you are using a single hand, we use the EC technique. The two fingers form the C and the other three fingers form the letter E. So we have to form a tight seal with the mask and then ventilate the patient. When otherwise we can use both hands and seal the mask on the patient's face. So before using mask ventilation, we have to do jaw thrust. Then oral and nasopharyngeal airways. So this oral airway, we have the Goodell's airways and many more airways. So most commonly we use Goodell's airways. So it extends from the lips to the pharynx. So it fits between the tongue and the posterior pharyngeal wall. It has the following parts: the flange, as you can see here in the image, we have the flange. Then we have a reinforced bite block portion, and we have the curved portion. There are many sizes and there's color coding for the sizes. It can be measured from the midpoint of incisors to the angle of the mandible. Goodell's airways, most frequently used. Large flange and reinforced bite portion with tubular channel for air exchange and suctioning. Then others airways like Waters airway. It has a metallic hollow oropharyngeal airway with two holes at the pharyngeal end. It is very cheap and reusable. Then the Safar's airway. Safar's S-shaped oropharyngeal airways. Then Copa This is called cuffed oropharyngeal airway. It is a modification of Goodell's airway with an inflatable cuff designed to seal the oropharynx. It has an integral bite block and a 15 connector for attachment for the breathing circuit. Then Patil Siros endoscopic airway. It is designed to aid fiber optic intubation. Made of aluminium, it has lateral channels and a central groove on the lingual side to allow passage of the fibroscope. A slit in distal end allows the endoscope to be manipulated in the anterior-posterior direction but limits lateral movements. Intubating airway. It is tubular along its entire length, open on one side so that it can be split and removed from a tracheal tube. Can be used as an oral airway or as an aid to fiber optic or blind orotracheal intubation. Then Williams airway intubator. Designed for blind tracheal intubation, can also be used for fiber optic intubation. It is available in two sizes, number 9 and 10, which admit up to 8 and 8.5 tracheal tubes. The proximal half is cylindrical while distal half is open on the anterior surface. So this is a method of inserting an oropharyngeal airway. It is first inserted so that the convexity is upwards. Then after passing the incisors, we rotate the airway and so that the concavity faces upwards and it is placed inside the mouth. Correct size is estimated by holding the airway next to patient's mouth with the tip at the angle of the mandible. So selecting the correct size is important. It is used to prevent patient from biting and occluding the endotracheal tube, protect the tongue from falling backwards, and also to prevent tongue bites, to facilitate suction, to obtain better mask fit. Complications include iatrogenic trauma, airway hyperreactivity, ulceration and necrosis of oropharyngeal structures, and dental injury. Nasopharyngeal airways. A nasal airway is better tolerated than oral airway in patients who have intact airway reflexes or in an awake patient. It extends from the nose to the pharynx. The pharyngeal end should be below the base of tongue but above the epiglottis. When in place, a nasopharyngeal airway is less stimulating than an oropharyngeal airway, hence better tolerated in the awake, semi-comatose or highly anesthetized patient. It should be avoided in cases of oropharyngeal trauma. In cases of oropharyngeal trauma, a nasal airway is better preferred to an oral airway. So these are the other nasal airways: Linder nasopharyngeal airway, cuffed nasopharyngeal airway, binasal airway. Consists of two nasal airways joined together and has an adapter for attachment to the breathing circuit. It can be used to administer anesthesia. So the indications of nasopharyngeal airway: tongue obstruction, inadequate oral opening or oral surgeries. Then we can use nasopharyngeal airways. The correct size is measured by holding the airway from the lateral edge of the nostril to the ear, tragus of the ear. It is well tolerated even in conscious patients. Sizes: large adult 8 to 9 mm of internal diameter, small adult 6 to 8 mm. Contraindications: hemorrhagic disorders or basilar skull fractures. Laryngoscopes. A laryngoscope is a device that is used to visualize the larynx and adjacent structures, mainly for inserting a tube into the tracheobronchial tube. So, it can also be, other uses include insertion of nasogastric tubes or Ryle's tubes, foreign body removal, upper airway lesion biopsies, visualizing and assessing the upper airway, vocal cords and the larynx. So the types: direct rigid laryngoscopes, indirect rigid laryngoscopes like fiber optics and all, and videoscopes, flexible fiber optic endoscopes, Laryngoscopes. Rigid laryngoscope. Parts include the handle and the blade. The handle is the part that is held in the hand during use. It provides the power source for the light. Most often, this is from disposable batteries. Fiber optic illuminated laryngoscope may use a remote electrically operated light source. The handle is a hinge pin that fits the blade on the base of that fits the hinge on the base of the blade. Handles are available in various sizes and have a serrated surface for improved grip. These are the parts of a laryngoscope blade, where we have the flange, proximal end, a distal end, we have a light source, and the middle part called the tongue of the blade. The tip is rounded to prevent trauma. We have Miller's straight blades and Macintosh blades. So these are the different sizes available, and this image shows a McCoy blade in which there is a hinge at the proximal end, and the when you press the proximal hinge, there will be a flexion at the distal end of the blade, which helps in lifting the epiglottis and better visualization of the vocal cords. So these are the types of the blades. Macintosh, improved vision Macintosh. It is similar to the routine Macintosh blade, except that the middle portion of the tongue is concave. It is concave, so it allows greater visualization of the larynx. Then Oxyport Macintosh, where we can connect the blade is designed in such a way that it can be added to the oxygen source. Then the Macintosh, it is a modified Macintosh that has a suction port near the tip. The suction channel extends next to the handle and has a longer control valve so that suction can be controlled by the laryngoscopist. Then we have the polio blade. It is used for it has a short handle at an obtuse short handle with an obtuse angle to the blade, so that it helps in patients with obese patients, breast hypertrophy, and with severe barrel chest deformities, or with restricted neck mobility. The other blades, Bizarre Gifford blade, flexible tip blade, or the McCoy blades. These newer blades, they help in better visualization of the larynx and help in difficult airway situations. This blade, the tongue is straight with a slight upward curve near the tip. It is used in pediatric cases. It also has other types like Oxyport, Miller's blade, Tull, Wisconsin, and Matthews. Coming to video laryngoscopes. Video laryngoscopy is a form of indirect laryngoscopy in which the clinician does not directly view the larynx. Instead, visualization of the larynx is performed with a fiber optic or digital laryngoscope inserted transnasally or transorally. The images from video laryngoscope can be displayed on a monitor for the clinician, patient, and others to view at the time of the procedure. It can also be recorded. Images are magnified when displayed on the monitor, allowing for detailed examination of the larynx. Indications: difficult airway situations, failed conventional laryngoscopy and intubation, diagnostic purposes, and teaching purposes. Evolution of the laryngoscopy started from 1940 with the normal blades. Then the first flexible fiber optic in around 1970s. Then the Bullard laryngoscope in 1990s. Then we have the AirTrack and CMAC, which have evolved in 2010. Karl Stoll's video laryngoscopes. First generation. In 2000, Karl Stoll developed with the patent of Professor Elias the first video laryngoscope. This shows the video laryngoscope with a handle blade connected to a video unit. Then second generation, Carl Stoss in 2001, which allowed for a smaller camera and more convenient handling. Generation VMAC. It was developed in 2003. Intubation scope, optical steroids, all can be connected via a one-chip camera system to the monitor, improving the video image. Then the fourth generation, 2008 CMAC video laryngoscopes with a short handle and a blade. It is equipped with a CMOS chip, LED light output, and lithium-ion battery, making the system highly portable and versatile. Glide scope. In 2001, it was designed, the glide scope. It incorporates a high-resolution digital camera connected by a video cable at a high-resolution LCD monitor. It can be used for tracheal intubation as well as for removal of foreign bodies from the air. The steep 60-degree angulation of its blade improves the view of the glottis by reducing the requirement for anterior displacement of the tongue. The digital camera is located at the point of angulation of the blade. This placement allows the operator to more effectively view the field in front of the camera. The video camera is recessed for protection from blood and secretions which might otherwise obstruct the view. Egrat laryngoscope. It is a portable video laryngoscope with a blade length that can be adjusted to facilitate a child of age 5 years up to an adult. The blade can be disconnected from the handle to facilitate its insertion in morbidly obese patients in whom space between the upper chest and head is reduced. The blade is inserted midline with the laryngeal structures viewed at a distance to enhance intubation success. Then the King Vision Scope or King Scope. It consists of a reusable LED monitor with handle and single-use blades. Blade tip has light source and high-resolution camera. Two types of blades, standard blade and a channel blade. Channel blade, we can pass the ET tube through the channel. Monitor is battery operated and also has port for video cable. These are the two blade types, standard blade and a channel blade. Pentax Airway Scope. It has a portable battery operated LCD monitor and a disposable blade. Blade has a guiding channel for loading endotracheal tube. An additional port for suction of secretions is present in the blade. In the flexible fiber optic laryngoscope. It uses flexible optical fibers to transmit images from a distal lens. The insertion cord contains bundles of optical fibers that transmit the image and a different group of optical fibers that transmit light to the distal end and cables from a control lever in the handpiece that flex and extend the distal section. The Holly channel can be used for aspiration of secretions or installation of local anesthetic. The simplest flexible fiber optic laryngoscopes have a proximal eyepiece. The image can be displayed on a monitor by attaching a camera to the eyepiece or by using an FFL with an integral camera. The FFL is the most versatile laryngoscope for tracheal intubation and can facilitate intubation that could not be achieved with any other technique. Awake flexible fiber optic laryngoscopy is the safest non-invasive means of securing a critical airway. So these are the components of a flexible fiber optic laryngoscope. Body, the tip deflection control lever and a focusing ring, eyepiece and a working channel sleeve. The insertion cord which contains the fiber optic bundles, optical system and a mechanical system. Light transmission cord or the universal cord. This is an image of a flexible fiber optic cord. The proximal end where you can see the focusing ring and a tip deflecting controlling lever. Functionality of the flexible fiber optic laryngoscope. Flexible and steerable, minimal tissue pressure and trauma, continuous visualization, oral or nasal route possible, other intubating devices may facilitate combination techniques, visual confirmation of the depth of intubation or withdrawal. Indirect rigid laryngoscopes. The Bullard laryngoscope, it has a rigid blade. Fiber optic bundles are housed in a sheath posterior to the blade. Then we have the view scope, upshur scope. These are the different types of rigid laryngoscope. Then we have optical intubating stillets, where the tip of the stillet has a camera, atraumatic tip, and it can be connected to it has an eyepiece and a handle at the proximal end, where the distal end can be visualized. Coming to endotracheal tubes. The ET tube is one through which anesthetic gases and respiratory gases are conveyed into and out of the trachea. It has a tracheal end and a machine end. The bevel is defined as a slanted part of the tube at the tracheal end. When an opening in the tube is present on the opposite side of the bevel, it is called a Murphy's eye. Standard markings on an ET tube. The markings are situated on the bevel side above the cuff and are read from the patient end to the machine end. Types: oral or nasal. Size: it is measured according to the internal diameter in mm. And the manufacturer's name or trademark is also present on the tube. It has graduated marking showing the distance in centimeters from the patient end. Usually they are disposable and we should not be reused. PVC tubes. Radio opaque lines may also be included at patient end or along the full length, which can be visualized in a chest X-ray. This is an ET tube with the Murphy sign, inflated cuff, a radio opaque line. Then it is connected to a cuff, and the cuff contains a pilot balloon, and it has a one-way valve. Then the the proximal end or the machine end has a 15 mm connector to be connected to the ventilatory circuit. Ideal ET tube, it should be inert. The smoothness of outer surface to avoid damage to mucosa. Inner surface should be smooth and non-wettable to prevent buildup of secretions. Non-inflammable, transparent, easily sterilized, non-kinking, sufficient strength to allow thin wall contusions, thermoplasticity to conform to anatomic passage and to be it should be less reactive with lubricants or anesthetic gases. Non-injurious catheter tip. Currently used tubes are manufactured from synthetic rubber, plastic materials and silicone. According to the type of the cuff, there are two types: high volume low pressure cuffs and low volume high pressure cuffs. High volume low pressure cuffs are the cuffs, the recent ones which we use now. The cuff, it can be inflated to high volumes, but it exerts a less pressure on the tracheal wall. Guidelines to determine the size of the ET tube. Ideal tube in an average adult male is 8.5 mm ID, and in an average adult female 7.5 mm ID. In children with ages less than 6 years, it is 3.5 plus age in years by 3, that is equal to, we get the size of the tube. Greater than 6 years, 4.5 plus age in years by 4. Depth of insertion, the tube should be in the middle third of the trachea with the head in neutral position. Following calculations can be used. Length in centimeters is equal to age by 2 plus 12, or weight in kgs by 5 plus 12. Length, or it can be height in centimeters by 10 plus 12, or 3 into the internal diameter. In adults, the tube should be passed until the cuff is 2.25 to 2.5 centimeters. Specific tubes. Cold tube. It is uncuffed ET tube designed for pediatric patients. The patient end is smaller in diameter, 2 to 5 mm, for neonatal resuscitation but not for long-term intubations. Spiral embedded tubes or armored tube. Metal or nylon spiral woven reinforcing wire covered both internally and externally by rubber, PVC or silicone. The stellate is often needed for intubation. Spiral, it's also called the reinforced tubes. These tubes are especially useful in situations where the tube is likely to be bent or compressed, as in head and neck surgeries or when the patient is placed in a prone position. Then we have some special tubes called the preformed tubes or the ring Adair Elvin tubes. And in this we have the south pole or the north pole. It is used for surgeries of the head and neck, cleft palates and cleft lip surgeries. Then we have the laryngectomy tubes designed for insertion into a tracheostomy site. Tracheostomy tubes allows part of the tube external to be directed away from the surgical field. Then we have microlaryngeal tubes designed for microlaryngeal tracheal surgeries. They have small diameters and longer lengths. Then tubes with extra lumens we have the laser tubes or the laser shield 2 tracheal tube. It is designed for use with CO2 and KTP lasers made from silicone with an inner aluminium wrap and a smooth Teflon outer coating. The cuff is not laser resistant and contains methylene blue crystals and should be inflated with water or saline solution. Laser shield tubes and laser tubes, it is recommended for use with argon, Nd:YAG and CO2 lasers. Then high-low jet tracheal tubes can be used for jet ventilation. Double lumen tubes designed to isolate lungs anatomically and physically in one lung ventilation. It has two tubes bonded together. Can be left-sided or right-sided. The longer bronchial lumen and there is a shorter tracheal lumen. And it has two cuffs, a bronchial cuff and a tracheal cuff. DLT is supplied in a package with a tube, stellate, connector and suction catheters. Sizes start from 26 French up to 41, 26, 28, 32, 35, 37, 39, 41. For an average adult female, 35 size is used and an average adult male, 37. So we have Carlin's, White, Bryce Smith and Robert Short types. This is the double lumen tube where we can see a bronchial lumen and a tracheal lumen. And we have two cuffs. The blue colored is the distal bronchial cuff and the white cuff is the tracheal cuff. Then we have a bougie, stellate and light vents. These are the other structures or airway equipments used which help in difficult intubations. Then we have the Frova intubating introducer. Then the light vent which can glow in lateral leg. It is tip when the tip is in the pyriform fossa, and it is in the when it is the glow is seen in the anterior neck and it is correctly positioned. Supraglottic airway devices. Supraglottic airway devices are those which are placed above the glottis and thereby help in providing adequate ventilation. Easy to operate, helpful in difficult airway conditions. Indications: difficult intubation conditions, small procedures, essential part of difficult airway trauma. Contraindications include airway edema, local pathology in upper airway, stridor, trismus, restricted mouth opening, active vomiting, in ingestion of acids, pregnant, obese patients, decreased lung compliance. Then supraglottic airway devices can be classified into first generation, second generation and third generation. First generation simple airway devices, low pressure pharyngeal seal, may or may not protect from aspiration. Example: the classic LMA, flexible LMA, Cobra, perilaryngeal airways, laryngeal tube. Second generation specially designed to reduce the risk of aspiration. It forms a high pressure pharyngeal seal, reduced risk of aspiration, may be more efficacious in ventilation. We have the Proseal LMAs, Supreme LMA, Slip-on, iGel. Then the third generation LMAs, they are the cuffless, LMAs which contain two drain tubes, a small bowl, also called the Busker mask. Based on the sealing mechanism, it is divided as cuffed perilaryngeal sealers, cuffed pharyngeal sealers, and a cuffless pre-shaped sealer. In cuffed perilaryngeal sealers, we again have non-directional, non-esophageal sealers. That is the classic LMA, flexible LMA. Then the directional non-esophageal sealers, fast-track LMAs. Then the directional esophageal sealers, which are the ProSeal LMAs or LMA Supreme. Without esophagals, in cuffed pharyngeal sealers, we have without esophageal sealing, that is Copa or PAX. With esophageal sealing, that is the combi tube, laryngeal tube or laryngeal tube Supreme. Then cuffless pre-shaped sealers we have without esophageal sealing, that is the Busker mask or IGEL. With esophageal sealing, that is the SLIPA, AirQ, SP. Then based on the number of lumens, single lumen devices, LMA classic, unique, intubating LMA, SLIPA. Double lumen devices, ProSeal, combi tube, laryngeal tube suction, airway management device. And triple lumen devices, Elisha airway. Advantages: increased speed and ease of placement, less requirement of inadequate positive expertise, less requirement, improved hemodynamic stability at induction and during emergence of anesthesia, minimal increase in IOP and ICP, increased airway tolerance, lower frequency of coughing during emergency. Disadvantages: vascular compression and nerve damage, sore throat, gastric aspiration chances are high, and high airway pressures. Then we have the classic LMA, comprised of three main components: airway tube, mask, inflation line mask. The mask is designed to conform to the contours of the hypopharynx with its lumen facing the laryngeal opening. Made of silicone, it can be autoclaved and reused many times. These are the sizes which have 1, 1.5, 2, 2.5 up to 6. And the maximum cuff inflation volume depends on the size, and it should be used according to the body weight of the patient. So this is the classic aperture bowl. Then we have an airway tube, inflation line, and a pilot balloon with a one-way valve and a proximal connector. PVC made, cheaper, less rise of intracuff pressure with nitrous oxide, more difficult to insert, sizes same as classical LMA. Flexible LMA, flexometallic tube, narrower and longer, has a rigid preformed angle at the cuff. Seal pressure is equal to 20 centimeters of water. Introducer helps to stabilize the airway tube during insertion, and it is removed once it is in place. Then the intubating LMA, a modification of the CLMA or classic LMA, a rigid anatomically curved short and wide bore shaft that follows the anatomical curve of the palate and the posterior pharyngeal wall. An epiglottic elevator bar at the mask aperture, armored flexible ET tube with a longitudinal and a horizontal black line, coincides with the epiglottic elevating bar. The stabilizer rod of 25 centimeters, seal pressure equals to 60 centimeters of water. This is an intubating LMA which helps in intubation in difficult airway situations. For a laryngeal mask and the soft seal laryngeal mask. Perilaryngeal airways or the cobra, it is in the shape of a cobra neck. LMA, pharyngeal cuff, ventilating shaft and a flexible mask grip. Laryngeal tube, introduced in 1999, consists of silicone reusable airway, short and J-shaped, blind tip, average diameter 11.5. Both cuffs are high volume and low pressure to avoid ischemic damage. It has an additional esophageal lumen posterior to the respiratory lumen that ends just distal to the esophageal cuff for suctioning and gastric tube placement. Then we have a ProSeal LMA, reusable silicone-made modification of CLMA. Modifications include esophageal drain tube, posterior inflatable cuff, reinforced airway tube. ProSeal LMA, reusable silicone-made modification of the classic LMA. It has an esophageal drain tube, posterior inflatable cuff, reinforced airway tube, integral bite block, and an introducer. It can be used with high positive pressures. This is an iGel, which is a pre-shaped LMA, cuffless, and it has a 15 mm connector, proximal end of gastric channel, clearly displayed product information, then the position guide. It has a integral bite block, buccal cavity stabilizer, epiglottis elevating block bar, and a distal end for the gastric channel. Non-inflating cuff, no aperture bars. It has an epiglottic rest or ridge. Then LMA Supreme, single-use PVC made second generation LMA, has features of ProSeal LMA, intubating LMA, and LMA Unique, single-use and PVC made. LMA C-Track enables combined ventilation, visualization, and the intubation. Laryngeal suction tubes. It's a double lumen silicone tube. Second lumen helps in gastric suctioning and insertion of nasogastric tubes. These are streamlined liners or slippers because it's in the shape of a slipper. Then the Elisha Airway, silicone made and latex free. 3 separate channels for ventilation, intubation, and gastric tube insertion. Then we have combi tubes. This design, named the trachea esophageal combi tube, is functional if introduced into the esophagus. Then ventilation being achieved through the esophageal lumen via the hypopharyngeal perforators, or in the trachea. Ventilation being achieved through the tracheal lumen via the distal aperture. Here, as you can see, if it is placed in the esophagus, then we have the laryngeal apertures through which ventilation occurs, or when it is placed into the trachea through the distal aperture. Buska mask is the latest generation of supraglottic airway devices. It is a cuffless device with a membranous bowl which inflates with each positive pressure and then deflates to atmospheric levels during passive expiration. AirQSP supraglottic airway devices. Thank you.